Doc, good morning and welcome to Sunday Breakfast.
Good morning.
Yeah. And I mean, earlier this week, was it this week where we had the check done here?
Yes.
Was this week?
It was last week.
It was last
Sunday
week.
is the beginning of a new week, so.
Okay, so yeah.
Last
I'm
week.
excited
about
and I've seen a lot more corporate institutions particularly jump on.
Yeah.
So for example, I saw that the NPA and the Ghana Gas also, did a whole awareness creation drive, through sports. I've seen many other private institutions do same.
Yeah.
It's the informal sector, our traders, our moms who sell in the market.
Yeah.
It's like they are the ones who have not really jumped
onto it. But it was actually yesterday I was part of the walk.
Okay.
Organized by the Breast Society of Ghana, where we started from Elwak Sports Stadium all the way to the Kaukudi market, and then
I saw a couple of my friends share Snapchat stories on this.
Yes. So at least that was a way to reach out to the informal sector, as you mentioned. A lot of the market women there had some flyers. They benefited from the talks, and thankfully the talks were done by our survivors. Okay, so most of the survivors joined in the walk, and they actually did the talks, encouraged people that they have been diagnosed before, they went through the treatments, and they are standing here today as normal people. So it's not all gloomy. There's always light at the end of the tunnel if you do catch it early and then you have the right treatment done. And this brings me to the importance of the theme, which is catching it early, treating it right, and
catching
then
it early, treat
it right, and definitely you will survive it. Okay, so yes, that was done, and a lot of the market women participated, and also the education was also done in different dialects.
Okay.
So we had somebody speaking Ewe, somebody speaking Hausa, somebody speaking Ga, somebody speaking Chi, just so that if you do not understand the English language that we commonly talk or we commonly educate in, then you also have the opportunity to benefit from the local dialects that was done yesterday. So I think it was a good program, and people benefited. They got some flyers as well, and these flyers, you have how to do your self-breast examination in there. And I'm sure even if they haven't done it and they are able to read those flyers, they should be able to walk through it and be able to have their self-breast examination.
I love that you used survivors to tell the story.
Yeah.
And I also love that you spoke to them in a language they understand.
Exactly.
So this is great, and well done to the team. This is the Breast Association.
Breast Society of Ghana.
Wow.
Breast
so
Society
what do they
of
do?
Ghana.
Just breast cancer awareness?
Breast cancer awareness, so advocacies, you have the surgeons, breast surgeons also part of it. And then you also have some survivors
as part of it. Wow.
So it's a whole team. You also have radio oncologists, so all the team, the multidisciplinary team that deal with breast cancer treatment from diagnosis all the way to treatment.
Is it solely focused on breast cancer?
Yes.
Are there, in fact, let me just ask, are there even other, ailments, that affect the breast?
Oh yes, there are. There are other benign conditions like fibroadenomas and all of that. So just a lump in there, but it's benign. So when you say breast cancer, it's more or less that one would move to other parts of it. It's abnormal growth that would not only stay at where it has started growing, but rather
grow
to other parts of the body. Yes, so benign would not move. It will stay wherever that it's, in whatever locality that it's located, and it won't spread to other parts of the body to cause problems. So yes,
so the Breast Society caters for all of that.
Yes, Breast Society of Ghana.
Shout outs to the leadership.
Yes,
this is
Dr. Ntafo, especially, she is the breast surgeon and also the president of the Breast Society of Ghana.
Nice.
Yeah. All right.
We focused on hand examination the last time.
Yes.
And,
I hope you were able to do it yourself.
Yes.
Good.
I have.
Yeah.
The way you looked away, is there an issue?
No.
Okay. Good. So I wanted to find out what, aside that, I know there's a mammogram.
Yes.
Is that different, or is that, like, what is a mammogram? Is it more in-depth?
Okay, so mammograms are investigations. So if you follow all our conversations, you notice that I always start with what the patient tells you. So those are, if you come to the hospital, you'd first have to tell me what is wrong with you. So the patient will tell you, and it's like a story, okay? So once the patient tells you, okay, I feel this, or I have a lump, or I felt that there's something somewhere, you know. So based on that, you probe further. After probing further, then you go ahead yourself and then do the examination, as we did the last time on the show, to show you, okay, so you go ahead and then do your palpation, your inspection, your palpation, and then go on and on. Then after that, the next stage is to do your investigations. So a mammogram is under investigations, okay? So mammograms, yes, so it's basically you taking x-rays of the breast. So what this is that when you go, there are two plates where you would have to position your breast, and then it would compress it a little bit, and then you would have x-rays going through the breast tissue so that it would give you a picture, and that picture would help you know. So it will just like you're taking a chest x-ray. So now you're taking films, or you're taking x-rays of the breast to be able to tell if there are any abnormalities associated with the breast. And it's recommended, it's very important in the diagnosis of breast cancer. It's recommended that at least if you are 40 years, you do either yearly mammograms, or you do every 2 years mammogram. Okay, so it's very, very recommended that either you do it 2 years or you do it every year. And then also the mammograms are also recommended for anybody who you may have to have it done earlier than the 40 years that I have mentioned. And that's when, if you have certain risk factors. So if you do have maybe a first degree relative who has been diagnosed of breast cancer, you would have to start your mammograms not at 40 years. You start it earlier, and it's personalized based on the time that that first degree relative was diagnosed of the breast cancer. So usually we say 5 years or 7 years earlier than the age at which that first degree relative was diagnosed. That's when you would start doing the mammograms, so that you'll be able to catch it early if you are developing any breast cancer. So it's not painful, because some people will say, oh, it's painful, but it's not. It may just be a little uncomfortable when it comes towards the pressing, when you have to press in, the breast tissue in between the plates and then do the imaging. And it takes just some few seconds. After that, you should be fine. So you may have to deal with just a little bit of discomfort for those few minutes. Is it very
intrusive?
And then, no, it's not.
Is that Chris?
It's
Chris
not.
is getting it done.
Okay, so that is basically what a mammogram is.
How often?
And
okay, you mentioned how often you should get
which
it.
I said yes. So if it's 40 years, every year or every 2 years.
Okay.
And then if you have been diagnosed, or you have a first degree relative who has been diagnosed of breast cancer, then you have to start it at an earlier age, which is personalized. Doing it 5 to 7 years earlier than the date at which that first degree relative was diagnosed.
Is that expensive?
No, it's not. Mammograms are not expensive to do. They are not expensive to do. The adjunct is the ultrasound. Okay, so the ultrasound, now it's not, the gold standard is still your mammogram, but you can use ultrasounds as an adjunct. So maybe, for instance, in cases where you have patients who have very dense breasts, okay, and the mammogram is not clear, so you can use the ultrasound, which would give you extra information on whatever lump that has been detected. So the ultrasound is just is a probe. So you use a probe and a gel around the breast or around the lump, and then it uses sounds, okay, to be able to give you or to be able to draw a picture of the breast or the lump or the pathology.
Is that what we have on the
associated screen? Yes. So that's an ultrasound. Okay, so those are the two differences. And then there are certain times where patients may have some contraindication for having a mammogram done or having an MRI done. Then in those cases, you can use the ultrasound for the investigations of
men as well.
Yes, definitely. The ultrasound, you would be able to, but the mammogram you can, because your breast is not, you don't have a lot.
No,
well, those who have
can do it, right?
Yes, those who have the breast tissue, you should be able to have that done. So that is basically the investigation of breast cancer. And then that's the imaging aspect of it. The other aspect of investigations when it comes to breast cancer and breast pathologies would be you doing a histopathological examination. Cool. So for that, you would have to do a fine needle aspiration cytology, and then or FNAC, and then it's not difficult. It's not painful, and then that would give you the histological diagnosis. So the few cells that are taken from the lump would be sent to the lab, and then it will be examined under the microscope, so that you'll be able to tell the particular type of abnormality that that particular specimen has. So that's another that you do. Then, depending on if you are doing a metastatic workup, you would also want to do a chest X-ray, and then an abdominal ultrasound. So all of these would help you diagnose and stage the tumor. So remember, I always say that when it comes to cancers, it's very important that you stage it, because the staging directly affects the kind of treatment that you can give that particular patient. So for you to stage it, you need to look locally at the size of the tumor, and then you are able to give a T staging. Then after that, you would have to look at the regional lymph nodes, and then also give a stage to it. Then you look at the distant metastasis. Because it's cancer, likelihood is that it can travel to other parts of the body. It can go straight into the chest, and then you end up with complications of what's pleural effusion, and then it affects your breathing. You know, it can go into the spine, and then now affects even walking and all of that. So you need to do a holistic investigation of the entire body, so that you can give a particular staging to the tumor, and based on that, whether it's early stage or it's late stage, you'll be able to recommend a particular treatment for the patient. And the treatments are varied. So you have surgery, that's you doing a mastectomy, okay, taking away the breast and then the pathology associated with it. And then you can also have chemotherapy, and then radiation therapy, and then sometimes you can even have targeted therapy depending on the biology of the tumor and the state of the tumor. So these are some of them. And then sometimes it's even palliative, where you'd have to do you just palliate, and just palliate. Let me leave it as such. So these are the treatment modalities that are available, and then the investigations that we have mentioned as well. And then this would still bring me to some of the risk factors. I think we can just go through some of the risk factors associated with it. So being a female is number one. In fact, being female and then aging and then growing, they are the two topmost risk factors. Okay, so being female means that you would have some breast tissue, and then aging means that as you are moving, you know, as you are growing, your cells are dividing. Your cells, when they divide, that's the only way for you to grow. But then the division at the cellular level affects the genetic material or the DNA. Okay, so as you are aging, likelihood is that there may be some mutations happening, or there may be, when the genetic material is dividing, you may end up having certain anomalies that may not be able to be corrected. So you are able to, you would accumulate a lot of these aberrations that may end up becoming cancerous. Okay, so that is what it is. And then also we've already mentioned the first degree relative or family history of breast cancer. Sometimes even in other cancers like ovarian cancer can even predispose you to developing breast cancer. And then obesity. Obesity to a large extent due to the fact that you end up having certain or high levels of estrogen, which is a hormone that helps with the development of the breast. So if it is helping with the development of the breast and there's any abnormality or there's any growth within the breast, it would also feed it, and then you end up having, the lump itself developing. And then genetic predispositions. So certain genes have been associated with developing breast cancer, like BRCA1, BRCA2. So all of these are some of the risk factors associated with the development of breast cancer. Yes, and then maybe you can touch on some of the myths associated with breast cancer as well. So it's important in our education, in we trying to empower people with knowledge. We need to demystify some of these myths because it's important. It goes a long way to affect the patients right from diagnosis all the way to treatment, and then they having to survive this disease. So some of the myths, maybe, I don't know if you've heard any.
Oh, a lot, actually.
Many, but I think
they say
over
that
time,
if men suck the breast.
Okay, I knew this one was going to feature.
Over time, I think, again, the likes of persons like yourself, you've done so much work in demystifying and like changing a lot of the erroneous perceptions. And all. I just started even hearing anything about no brandy.
It happened. I think it was either,
I think,
12th or 13th, yeah.
13th
Wow, more serious now.
13th October.
Or maybe you are just growing.
Just grew up.
Yeah,
that's the only thing, but it was there.
It was there. I think I saw it some way, somehow.
Yeah.
Yes. So the sucking, very important. People mentioned that, if you have all sorts of people sucking the breast is protective. But that's not true. There hasn't been any research to show that you having somebody sucking the breast would reduce your risk of developing breast cancer. Rather, it is the suckling for the child that affects the hormone levels, and that is protective. So once the child is suckling, it means that there's high levels of prolactin. Prolactin is a hormone, and then it reduces the estrogen levels that would otherwise have fed the breast and then aided in the development of their breast, and then if there's any tumor in there and all of that. So that is the only thing that has been documented and proven by research that is protective. But aside that, any other adults sucking the breast does not have any protection for developing the breast cancer.
Interesting.
So that is one
there
of
are also, concerns around, those who are, survivors, or even let me just say those who are like going through the process of treatment.
Yeah.
There are certain concerns around what they can do and cannot do.
Yeah.
So, for example, if you're a mother and you have to deal with the ordeal of like treatment, can you still go ahead and like breastfeed a baby?
So at that moment, most of the time, it's a very gray area, and it's a very difficult area to have to deal with breast cancer in a patient who is, let's say, breastfeeding.
But there are cases like that.
Yeah, there are cases like that. There are cases like that where it depends on when even the diagnosis was made. Sometimes in pregnancy, sometimes at an early, even in the pregnancy, at what stage? Is it at the first trimester, second trimester, or the third trimester? All of these, and you need to go through thorough examination to be able to make a very good decision as to how you want it treated. Whether you want to go ahead with the pregnancy, or you want to terminate and treat yourself, and then so on and so forth.
Wow.
And it becomes very difficult because at that stage, what are the odds? You know,
wow.
So it's a very difficult and complex.
But you treat it on a case-by-case basis.
Yes, case by case, and it's personalized. So
Yeah.
I have mentioned the treatment modalities as available. Having a mastectomy, having the chemotherapy, having radiation therapy, having targeted therapies, and some immunotherapies as well. So now it is breast cancer treatment is case by case, it's personalized. It's not one size fits all. So depending on the biology of the tumor, then you would be
and the extent of that
exactly the spread. So the staging. That's why you have to always stage it from onset before you.
And based on available research, you know, there may be instances where you may be able to keep your baby.
Yes.
And
there are certain patients who would say, okay, based on this and based on the advice of the health professional, I would want to keep the baby till I deliver, then I can take care of myself.
Yeah.
But as I say, it means that you would have to deal with the growing tumor as you are keeping the baby. You would have to deal with you having, that means that if the tumor is growing, the stage is becoming higher. You may end up moving from, let's say, a stage 2 cancer to a stage 3 by the time you deliver. So it's a very complex thing that needs to be looked at holistically with the patient and the other team that would be looking at, because you can't have chemo or radiation at certain stages. Some of the chemo and then radiation therapies are not compatible with pregnancy.
Yeah.
So you'd have to look at all of these, and it's usually personalized.
And also maybe talk about this for us, right? Is it always the case where someone having to treat breast cancer would end up having their breast, you know, removed?
Yes. So there is one of the myths that, oh, once I have breast cancer, it means that I have to, you know, I definitely would have to cut off my breast, or I have to have surgery to take it out. So based on the biology of the tumor, as I mentioned again earlier, yes, there are certain times that, depending on the biology of the tumor, you may end up having other treatment modalities and not necessarily surgery. So it depends on the biology of the tumor. You can end up having either you do the surgery or you do other less invasive treatment options available. So yes, it's there. And another myth that I thought we were going to talk about is the fact that the people think that once you have been diagnosed of breast cancer, you can't shake the person's hand, or you can't even eat, share
those
a
are
meal.
like cultural
misrepresentations. Yes, and it is very, very important. It is very important that we actually tell people about it, because mentally it tends to affect these patients who are going through it.
Right.
Imagine you have somebody who is being treated for breast cancer, who lives in a compound house of some sort, where now all the other parents in the other homes would tell their kids not to even go to this patient who has been diagnosed. Imagine the kind of social isolation this patient is going to face. And certain times, when they even use some cutlery or utensils, they don't want to touch it, because they think that, what's the misconception here? They think that it is contagious, and that once they do share a meal or they do share some of these utensils with the patient, they are going to contract it, and that is erroneous. That is really erroneous. And rather, these acts will rather go a long way to affect the mental health of this patient, and would not help this patient survive, or will not help this patient have a clear mental health and know that he or she is being supported by their social circle. So it's very important that we let people know that you sharing a meal, you sharing maybe some sort of cutlery with these patients, you would not contract breast cancer.
There's some questions here for you. Hello, good morning. Please ask doctor whether there are other options for a nursing mother who has been diagnosed with breast cancer?
Yes. Yes. So as I said, yes, there are options. If it's a nursing mother who has been diagnosed, she needs to go to her primary health care physician, and based on the tumor biology, the right treatment modality would be prescribed for her. So there are options that are available.
Natasha from Wager wants to know whether the cancer can return after treatment.
Yes, so there are certain times where you have tumor recurrences. Okay, so that is why the treatment modality is multifocal. It's not only one type of treatment. You may go in, do surgery, take out the lump, take out the breast, but then you would have to continue with some targeted therapy or continue with chemotherapy or chemoradiation therapy. So this is to help make sure that you are in remission, okay? Certain times where you may have been cancer-free for even a number of years, but then the fact that you have the other breast there still puts you at risk of developing.
What if you've had a double mastectomy?
Then that is fine.
Then that's fine.
Yes, that's okay. So all of these are certain. There are certain times that yes, you may end up having recurrence of the tumor. Yes, but then you would have to continue and then complete the treatments, because you would have some chemo given after the surgeries, and that would go a long way to prevent recurrences of these tumors.
Another one, Martina from Ashaliboche is asking, I once used a brassiere overnight and it gave a mark on the left breast. As time went on, I felt a sharp pain in that area. Could it be a sign of breast cancer?
Okay, no. So, you see, I mean, wearing a brassiere depends on, usually you would want to look at what? Your cup size. It's important. It's important that you have a cup size that fits your breast, so that you don't end up causing any compression with your, it's supposed to be comfortable. You know, I know there's no bra day where people would even say that, you know, you removing your bra and then you not, it's protective, but no, it's only, the brassiere is not supposed to compress on your breast. It's supposed to hold and give it a fit. Okay, so she having that is likely she doesn't have the right size of the bra, and then it may have had just a little bit of some inflammation around it.
Yeah.
So she needs to go on and then do her breast examination. And what we have mentioned here, if you are from 20 years, you start your breast self-examination at home. At least you do that once every month, 7 days after your menses, okay, if you are premenopausal. And then if you are postmenopausal, you choose a particular date within the month so that you do it. So now that we are actually in the 10th month, I'm sure most of our listeners should have done about 10 self-breast examinations, okay? So it's important that she does that. If she's not sure, she needs to have it checked at the nearest hospital, so that once that, I mean, and also we've also mentioned that if you are from 40 years, you have your annual clinical breast examination. Then if you are from 20 years all the way to 39, you do that every 3 years. So those are the schedules that you can follow.
Interesting.
And yes, if there is any abnormality, it will be detected, and the needed treatment will be given to her.
Good. I think you're good. You wanted to say something? Or
no, you answered it along the line. It's fine.
Okay.
Thank you so much, Doc.
Doc, we appreciate you. As usual, thank you so much for this conversation on breast cancer. And I hope that, you know, people will go get tested. Not just in the month
and
of October,
I'm happy the ladies of ChannelOne have been screened.
Yes.
Oh, and the guys too.
Oh, the guys too.
Fantastic.
Yeah. That's nice. Yeah. So I'm very happy that everybody has been screened. And we'll continue. Let's not wait till October. Okay?
Yes.
So in November, all the ladies should have done their self-breast examination as well. Okay, and in December, you continue like that. And then with the age brackets that I have mentioned, if you need mammograms, make sure you are doing your mammograms, your annual or your biannual mammograms done for you if you're above 40 years. And if there are any changes or first degree relative or genetic predisposition, that would have to be personalized so that you start early. And remember, let's catch it early and treat it right, and definitely we will survive we will survive breast cancer.
All right, Doc, thank you so much. Well, on that note, we're going for a quick break. When we come back, we have from our correspondent. Do stay.